everyone. I'd just like to acknowledge the people also listed on the first slide here who have helped me very much with this project. The Rapid Response Team was initially implemented to improve the recognition of and response to deteriorating patients. The service aimed to identify patients with reversible deterioration to avoid preventable morbidity and mortality. However, multiple recent studies suggest that the Rapid Response Team is also involved in the recognition of patients who may not benefit from aggressive, invasive and burdensome therapies. In approximately 1/3 of Rapid Response Team calls, the patient will have a documented limitation of medical treatment. In most of these patients, the limitation of medical treatment will be pre-existing. However, in approximately 1/3 of these cases, or 10% of Rapid Response Team calls overall, there will be a newly documented or increased limitation of medical treatment after the call. An approach to end-of-life Rapid Response Team calls has recently been published, which you can see here on the slide, to guide registrars through the process of the initial assessment, management and communication in relation to such cases. The objectives of our study were to document how registrars triage the Rapid Response Team call within the first 5 minutes of that call, to document issues around communication and prognostication and end-of-life care discussions, to document and assess levels of associated registrar distress, and to document differences in baseline characteristics of patients and outcomes based on the initial triage and documented goals of care before and after the call. So this was a prospective observational audit of consecutive Rapid Response Team calls. All hospitalised adult patients who received a Rapid Response Team call at the Austin Hospital were included. And we collected data from a form filled in by registrars following the call and also from the Austin Rapid Response Team database. So most of the data was collected from the Rapid Response Team database, including patient demographics and outcomes. And we also collected some data from the registrars. So within the first 5 minutes of attending the call, the ICU registrars were asked to make an assessment as to whether the call was an obvious end-of-life care Rapid Response Team call, obviously not an end-of-life care call, or uncertain. And this was recorded on the form on the right of the screen there. We weren't prescriptive about exactly what an end-of-life care call is, as it was the registrar's impression that we were most interested in. However, an end-of-life care call could have included those imminently dying who would not benefit from resuscitation and those with advanced irreversible pathologies who would not benefit from ICU level care. And for example, that might be an 85-year-old patient with metastatic cancer and recurrent malignant pleural effusions having Rapid Response Team calls for low oxygen saturations. And we also asked ICU registrars how they gathered further information to aid in decision making. There were 401 Rapid Response Team calls during the 10-week study period, and the median patient age was 67.5 years. Limits of treatment were present in 18% before the Rapid Response Team call and 23.7% afterwards. Overall mortality was 20.7% during that hospital admission. .270 calls out of those 401, so that's 67.3%, had a form completed. 71% of calls were triaged as obviously not an end-of-life care call, 10% were triaged as an obvious end-of-life care call, and 18.5% were triaged as uncertain. Obvious end-of-life care calls were more likely to have limitations of medical treatment before the call than those which were uncertain. In terms of gathering further information to guide prognostication and management, most discussions were actually between registrars, whether that be the home team registrar or the covering registrar. Rapid Response Team calls were not discussed with the home or covering registrar and consultant in about 50% of cases. Consensus regarding ongoing management was achieved in the vast majority of cases, and that's consensus between ICU and the home teams. ICU admission occurred in 7.8% of obviously not end-of-life calls, 3.7% of obvious end-of-life calls, and in 8.2% of uncertain calls. In-hospital mortality was 6.2% for obviously not end-of-life calls, 66.7% for obvious end-of-life care calls, and almost 40% in uncertain calls. Registrars reported distress in 17 calls, which is 6.3%, and the most distress occurred in those calls which they triaged as uncertain. Our data is consistent with previous studies showing that approximately 1/3 of rapid response team calls involve end-of-life care issues, and diagnosing and managing end-of-life care issues now forms a significant part of the rapid response team's workload. If we continue to perform this role, then this certainly has implications for our training and for ongoing staff and resource management. Many of these deteriorations are reasonably predictable, and I think that having early end-of-life care discussions and planning for deteriorations could relieve a significant amount of workload from many ICU teams that are already stretched. And more importantly, this will also be better for our patients. If consensus between home teams and ICU regarding ongoing management and limitations of medical treatment are achieved the vast majority of the time, then why can't we be having these discussions earlier? If we can all see that limitations of medical treatment and end-of-life care planning is required, then we should be telling our patients too, so they're not surprised in the middle of the night when a stranger has to explain to them that they're dying. I think we should encourage ongoing discussion with parent units when rapid response team calls occur, and I think we should encourage them to become more involved in end-of-life care planning and discussions with their patients. The number of cases that caused registrar distress was not insignificant, and I wonder if we had asked them if they felt frustrated or sad or even disillusioned, there would have been even more reporting. And finally, use of the triage system, which I showed you earlier on in the presentation, may help registrars efficiently manage these cases. Thank you.